Here, let's start with HIV drug resistance. HIV drug resistance mutation arise in response to suboptimal ARV pressure, and they do lead to viral load failure. And high levels of HIV production and turnover create a quite impressive heterogeneity of viral populations of HIV. And process of reverse transcription of viral RNA into DNA is particularly prone to mistake, which is to error, which makes NRTI and NRTIs a prime DRM target. PIs and INSTIs have significantly lower rates of HIV drug resistance, and within each class of individual ARVs, we rank the drugs according to lower or higher resistance threshold. Well, let's look at what drives pediatric drug resistance. I will start with a smaller contributor, HIV factor, just subtype and innate resistance. But there is a bigger contributor, which is ARV factors. These are vulnerable drugs and regimen, PMTCT ARV exposures, drug-drug interactions, suboptimal dosing and absorption, and limited pediatric ARV choices. Well, bigger even than ARVs are ART adherence. We know that caregiver, family, child, or teenage education, motivation, capacity of paramount importance. We know of the huge elephant in the room, such as disclosure and stigma, and multiple social and economical factors impacting adherence. And finally, another very bigger factor there is programmatic factors for which we are responsible for, and those include suboptimal care and treatment services, limited caregiver family support, challenges with procurement of pediatric ARVs, and suboptimal health system capacity. But let's look at the types of HIV drug resistance in children. On the top, you are seeing a most common type of HIV drug resistance is acquired HIV drug resistance, which arises as a result of antiretroviral treatment. However, you can also acquire at the bottom the HIV drug resistance prior to even your diagnosis, so going on ART. This is called treatment-acquired resistance, and this is development of resistance after exposure to maternal ARVs during pregnancy, breastfeeding, or exposure to postnatal neonatal prophylaxis, or PNP. Therefore, the pretreatment resistance in children can be acquired. But there is another mechanism for pretreatment resistance in children, and that one is driven by the transmission of the resistant virus from the mother to the child during pregnancy, delivery, or breastfeeding. Let's start with the pretreatment drug resistance, so PDR. We do know that PDR contributes significantly to virological failure in children, and we also know it is much more prevalent in children with PMTCT exposures. PDR to anchor drugs has been led by NNRTI in the last decade, with prevalence as high as 70%, and a couple of reports from South Africa and Haiti in the DTG era continue to show high rates of NNRTI PDR. The prevalence of PDR to the anchor drug with a high resistance barrier, such as PI, has remained consistently low. How about NRTIs? The prevalence of PDR to NRTIs is between 10 to 25%, led by M184V mutation, which confers resistance to 3TC, FTC will be calling XTC, and decreases susceptibility to abacavir. And abacavir PDR has been reported in up to 20% of infants with newly diagnosed HIV in sub-Saharan Africa, though you might read some of these reports with some caution because it depends on your interpretation of abacavir resistance, which has layered resistance from a lower level to the higher level. Prevalence of dual abacavir XTC PDR among children varies. PDR varies quite widely, from 2% to 28% in Nigeria, and prevalence of the PDR to zidovudine and tenofovir remains low at less or at 10%. Available evidence suggests limited effect of these NRTI PDRs on the efficacy of the first-line ART regimen, given high rates of viral suppression on first-line ART and low rates of development of DTG drug resistance, though I might caution that in the young children, we do not have a scaled-up viral load. Only 1/3 of children under the age of 12 months are having the viral load tested, and therefore we really can't fully estimate whether it is working as well in the young children. Preparing for this talk, I have looked at the literature, what is available on InstDR during pregnancy and breastfeeding, trying to tease out the question of transmitted resistance. You have heard probably about South African cases recently, 3 women on TLD with virological failure in pregnancy and breastfeeding. The InstDRMs are listed on the slides, and zero transmission was the standard of care, PNP. 2 infants were breastfed. There is also published Italian case in a woman with perinatally acquired HIV, a multi-drug-resistant virus who was successfully suppressed throughout pregnancy with 3-TC darunavir DTG, standard neonatal PNP, no transmission, and 1 older report from IMPACT 2010 trial, no information on the infant, but case of maternal DTG resistance. Overall, I think we're seeing quite scarce data from extensive literature search. It just reminds us to consider PIs, and I'm referring to boosted PIs from my talk by calling them PIs in pregnant and breastfeeding women with DTG failure, confirmed DTG resistance, and the same principle should apply to the neonates born to women with DTG-resistant virus, DTG treatment failure. Potentially, though, I would say for DTG treatment failure, we really need to look at PDR to instis in children. And here are the data. Many of you have heard about Haiti case, but I have pulled the data also from Mali and South Africa together. The prevalence of PDR to instis so far from very scarce number of reports is low, 0 to 3%, and it's very hard to decide whether it is transmitted or acquired resistance, because we do not have usually information on the maternal DTG-DRT. Overall, the low rates of insti-PDR in children so far with very early and emerging data suggests that we have a right choice with the first-line DTG-based regimens in children, young children, and surveillance needs to go on so we can tease out this data more as we go forward. And I just want to say that the denominator there needs to be always kept in mind. The percentages I show you are against the samples with a variable insti-DRT results and not against the samples of infants who were exposed to DTG. Well, let's move to acquired drug resistance in children. We do know very high rates to resistance to NNRTI and RTIs and dual class resistance. ADR to PIs has stayed quite low at about 10% in the failure of the first allopurinol ritonavir-based regimen or second-line PI-based regimen children. And we do know from clinical trials in adults and pediatric the development of drug resistance following virological failure on the first-line DTG regimens is quite low. And here are the summaries from the WHO resistance report and Schaffer group from the clinical trials in adults, ART naive and experienced with viral suppression transition to DTG, the first 2 special rows, less or equal to 0.1% of DTG DRMs, and experienced transitioning with virological failure, 1.6% DTG DRMs, so under 3%. But looking at those children who transition with virological failure, with viremia to DTG-based regimen in clinical trials, Odyssey Penta and Impact 1093, the rates of DTG-DR are quite higher, approximately in the range of 20%. And why is it important? Because globally, viral suppression rates for children who transition to DTG-based RT with viremia are about 80%, and we do know that viral resuppression on DTG-based RT following intense adherence counseling is lower in children compared to adults. Well, let's start looking at beyond clinical trials at emerging real-world data on ADR to DTG. In recent WHO report, we've seen ranges in people living with HIV failing DTG-based ART from surveillance, PEPFAR-supported surveillance data, and there is clearly a range from 3.9 to 19.6%. South Africa has reported significant rise in DTG-DR following DTG rollout, and from these reports, if you look closer, they seem to be driven primarily by the high numbers seem to be driven by the patients who are transitioning to DTG-based RT with viremia. Well, how about children? WHO is conducting surveillance of DTG-DR in children. 1 is ongoing, 6 completed, 14 planned. But in recent cross-sectional survey with random sampling of viremic samples of people who have been on DTG 9 or more months, we have seen higher rates of major DTG-DRMs in Uganda, Tanzania, and Malawi in children compared to the adults. This emerging data on the high prevalence of DRM in children clearly requires surveillance, and we need to determine better the determinants of DTG-DR in the real-world cohorts. Risk factors for DTG drug resistance have been well identified. Those include poor adherence to ART, switching from non-suppressive ART, switching from PI-based ART, immune suppression, advanced HIV disease, TB, and opportunistic infections. And all of these risk factors, actually not most, but all, are more pronounced in children, placing them at higher risk for DTG-DR development compared to the adults. Well, let's look at our sequencing. Now that we look with you at the prevalence, what sequencing choices we have. Here are the WHO tables on sequencing between first and second lines for adult and children, and between them there are three major differences. We do not have TDF in the first or second or third line in RTR recycling for kids. We do not have darunavir in the second line for children, and we do not have adults transitioning from lopinavir regimen to the DTG regimens and are using extensively abacavir in the first line. And, with this sequencing, there are three questions that arise. When and how to transition children with virological failure from DTG-based ART? What NRTI backbone to use in the second and third line? And how can we optimize PI choices in the second line ART and potentially third line as well? But before I move on answering these questions, I want to start by asking a question: is switch always necessary? First of all, we need to eliminate the switches that are due to the stockouts of ARVs, and the data showed that they're still very high, including anchor drug switches. Second, we need to work on the adherence. Adherence challenges, despite the wonderful formulation of PDTG, remain very high, as shown on the data on the slide, because parents still need, or caregivers still need to administer two separate formulations. And the PALD gives an amazing opportunity to make a switch without changing the regimen and the drugs, and we need to really prospectively collect data on whether the introduction of FDC is going to improve our rates of viral suppression in young children. We do want to be like adults. We want to have more children for more options for young kids. And XTC TDF has been shown to be superior to abacavir in adults. Why not to have it for children? In the resource-rich countries, high-income countries, this is a first-line preferred regimen in combination with Instis. PADO has placed XTC TAF on the priority list. And while we still don't have separate XTC TAF formulation, we are close to getting the fixed-dose formulation of 3TC TAF and DTG in infants and children, and the availability of this fixed-dose formulation will definitely change the landscape of our first ART regimen for young children. I probably will not be able to give you a clear answer when and how to transition from DTG-based ART. The current timeline for the switch is about over 12 months to 2 years. And switching from failing DTG regimen is not simple. The majority of the cases we are moving to the high bill and dose burden, so it's not an easy decision. It needs to be done by multidisciplinary team. And what I would like to emphasize, instead of looking at the calendar timeline, I think we should be looking at the circumstantial switch that is driven by the capacity to adhere to the new regimen and monitor the outcome. Drug-resistant testing can be useful, but it usually involves the engagement with centers of excellence, treatment working groups, and this all affects switch line decision-making. We do know of multiple barriers with DRT, and in reality, we really don't have yet full data on the efficacy of DRT in managing pediatric ART treatment failure, and this year at CROI, we have seen some randomized trial that spoke about lack of efficacy compared to standard of care management. Well, let's look at the second question: what NRTIs to use in the second line with DTG? Well, we're all concerned because we know of high and intermediate abacavir drug resistance levels being prevalent in children with virological failure. But we also know from adult, well-designed randomized clinical trials that ARVs with high resistance barriers, starting with EARNEST trial and NADIA trial, such as PIs and DTG, have shown efficacy even with a fully compromised and resistant NRTI backbones. And NADIA trial has demonstrated superior efficacy of XTC FTC-TDF over AZT3TC when used in combination with two strong anchor drugs. And upcoming Odyssey trial drug resistance data, even with high-level abacavir-resistant children on abacavir, had lower virological rates versus those on zidovudine in DTG arm. All this data together are signaling that we might not need to switch the abacavir 3TC backbone, and actually maintaining that backbone during transition from failing regimen to DTG also offers us the benefit of once daily ART regimen dosing. And very, very exciting data looking into formulation which we do not have yet as a generic option for sub-Saharan Africa and other resource-limited settings is a CHAPAS-4 trial, which conducted two-level of randomization in children failing an NRTI regimen. First level randomized an RTI backbone, looking at tough FTC versus standard of care abacavir 3TC, zidovudine 3TC. Second one randomized DTG against currently available boosted PIs. And it's very clear in the study shown on the figure, and studies just published, there's actually a nice and clear picture on online available version, demonstrated superior efficacy and safety of tough FTC compared to abacavir 3TC and zidovudine, and resistance data presented here at the abstract 23. And in a real world pediatric adolescent BPI multi-country cohort, the use of once daily TLD was also a predictor of viral suppression on DTG. So really we need to put more pressure on the generic manufacturing of XTC-TDF for children. And last question is regarding the choice of protease inhibitors. We do know that these are the drugs with a high resistance barrier. Even in failing children, we have low rates of the resistance to PI, suggesting primarily poor adherence. No wonder poor adherence. These are toxic drugs with high palatability and tolerability challenges. Lopinavir, ritonavir requires twice daily dosing. We all have been facing a lot of stockouts in recent years. Darunavir, on the other hand, has the highest resistance barriers within the class, has beneficial safety profile, and introduction of generic darunavir, ritonavir starting at 12 years and 35 kilograms of age, 35 kilograms has really optimized the choices for adolescents and adults. Well, CHAPAS-4 trial did not show the high efficacy, but showed trend to be darunavir, ritonavir to be superior, and I would argue that there could be also some element of adherence there, because we do know that in this trial, lopinavir, ritonavir, atazanavir, ritonavir were co-formulated, and darunavir required different administration of boosted ritonavir. Safety outcomes for the lopinavir, ritonavir were worse for the weight gain and lipid profiles compared to atazanavir, ritonavir, and DRVR. And in our New Horizons data, we have shown that even in children with failure on PI and DTG treatment, DRVR is still best preserved sensitivity to antiretroviral gas susceptibility across all ages. The drug has been put on PADO 5 priority list, and on behalf of CHA in the room, I'd like to acknowledge the recent filing with FDA of fixed dose formulation of darunavir, ritonavir available for children starting 3 years of age, because it is not approved for use under this age. And this generic formulation will allow us to reconsider choices of PIs in the second line for children with confirmed DTG failure and DTG drug resistance. Well, how about multi-drug resistance? We have seen some interest in potentially straightening the regimens with second generation NRTIs, but the cross-resistance to rilpivirine and doravirine is quite high in treatment-experienced children. And RTI-free regimens with DTG and darunavir, ritonavir have been shown to be effective in adults, but we only have pediatric trial in suppressed patients going away from triple oral ART. But the interest to using NRTI-free regimens is growing, and there is ongoing current trial switch all in viral suppressed children of DTG rilpivirine, and planned trial in lenacapavir and bictegravir. Finally, attachment inhibitor for stemsivir is being tested in children. It's being developed in children right now in the PEN-SHIELDED trial. And just to finish up here on the potential choices, we do know that some emerging data suggest potential efficacy in adults and in one adolescent cohort in the US of rilpivirine in children and adolescents failing oral treatment, and also combination of CAB with capsid inhibitor lenacapavir for people with rilpivirine resistance is going to be explored in adults. In summary, Available pediatric anchor ARVs. We can celebrate. We have two first high drug resistance regimens to recycle. So we are in a much better space than we were in an NRTI era. Yes, there are dosing and tolerability burden, but it is a much better space. Sequencing of ART regimen with DTG may not require recycling of the abacavir 3TC backbone in children. TAF FTC is superior in the second line. Generic pediatric formulations are needed. And introduction of the new two generic formulations, which I described, will definitely allow us to optimize initial and sequencing ART choices for children. Higher rates of DTG-DR in children do highlight the need for ongoing surveillance, but I would argue they even highlight more that we need more evidence-based effective adherence support for pediatric ART. We need to scale up and optimize viral load monitoring, and we need to track the treatment failure cascades in the countries for pediatric treatment failure to be identified what is the culprit of our DTG-DR. And finally, for those with resistance, we do need more treatment options for children, including them in therapeutic novel agents, trials, and long-acting formulation development for children. I'd like to finish first by acknowledging children, adolescents, and adults whose lives have been affected by HIV and living with HIV, and those who are faced with it in daily life. I'd like to also thank a wonderful crew of the pediatric people listed on the slide: Lynn, Elaine, Stephanie Hackett, Christine Malati, Anna Turkova, Nandita Sugandi, Martina Penazzato, and a few grown-up people who actually opened the door to the discussions about children, and these are Daniel Kuritsky, Nicholas Patton, and Michael Jordan, as well as PADO, PAG teams, GAP, and US guidelines panels, and many of you in the room without whom this work would not be possible. Thank you.